Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei niin kuin ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm an anesthesiologist and I'm proud to be an intensivist. We, intensivists, are working together to fight COVID-19. Together, we are intensive care medicine.
Hi, I'm proud of being an intensivist. We are fighting COVID-19. Together, we are intensive care medicine.
I am an anaesthetist and I'm proud to be an intensivist. We are working together to fight COVID-19. Together, we are intensive care medicine.
I am an intensivist and proud of it. Intensivists with various specialty backgrounds work together as a multidisciplinary team to prevent and treat temporary risk of death due to COVID-19.
My name is Jan de Waale and I'm proud to be a surgery-trained intensivist and work in intensive care. We work together to beat COVID-19. Together, we are intensive care medicine.
Good afternoon, good morning, good evening. I would like to welcome everybody who has dialed in to listen to this webinar. We've just heard all together we are focusing on fighting COVID-19. And as part of this fight, I'm very grateful to the ESICM for arranging another important webinar. It's an honor to chair this webinar, which focuses on optimizing antibiotic therapy in COVID-19. We have two expert speakers who will give talks with the aim to provide guidance and tools for antimicrobial stewardship and antimicrobial therapy. The talks will last about 20 minutes, and after each talk, there will be enough time for questions. So I'd like to invite you to put your questions into the chat box, and I will then ask them during the break for questions. Without any further delay, I'd like to introduce the first speaker, who is Professor Jan de Waale from Ghent in Belgium. Jan obviously has many roles and is well known to the audience. He's given lots of webinars as part of the COVID series already. And today, Jan is going to give a talk on upholding antimicrobial stewardship principles in COVID-19 patients. Jan, over to you.
Hello, everybody. Good morning, good afternoon, good evening, good night, wherever you are. It's a pleasure and an honor to talk today on the importance of antimicrobial stewardship, its principles, and the application in patients with COVID-19. Thank you, Marlies, for the kind introduction. Now, I think it goes without saying that COVID-19 and the coronavirus is the biggest challenges most of us will encounter during our professional career. When you look at the figures, at the numbers, this is ever increasing, and it's clear that we haven't seen the last bit of it yet. Now, in the past few months, as we have been gaining experience, it's really fascinating to see how we forget about basic principles when we are under stress. And I do not only refer to the over-enthusiastic use of certain drugs that in the end may have caused more damage than actually any benefit, whereas in normal times we would say, let's just investigate this and let's only apply this once we have the proper evidence. Now, the same holds true to some extent for certain basic principles when we take care of our patients. principles that we have been throwing overboard or ignoring when the situation got difficult. I do think there's a window of opportunity, at least in most European countries. We've been past the first wave, and now we have time to reflect, to investigate on how we have been managing these patients, critically analyze our experience in order to help us better prepare for the next wave. And this is the perspective I will take in the next 20 minutes. I will focus on antibiotic use, the principles, and how to uphold antimicrobial stewardship principles in these difficult situations. So let's go back a few months. It's really difficult. Maybe let's go back to January, February. We knew about the coronavirus, but still we've been discussing a lot about the problem of antimicrobial resistance, about how to hold antimicrobial resistance, how to use our drugs, the old drugs, the new drugs, in an optimal way. This was the estimated impact, or this is the estimated impact still of antimicrobial resistance by 2050. This comes from the O'Neill report from the UK, and it's clear a lot of patients will die from antimicrobial resistance in the years to come still. So this hasn't really changed with COVID-19 maybe taking over for now as an important cause of mortality in our units, but certainly antimicrobial resistance will persist as well, and will also confront patients who are now in our ICUs. So then, of course, the coronavirus came. In fact, antimicrobial resistance probably got worse in the past few months. We don't yet realize this, and I think the combination of COVID-19 and the background of antimicrobial resistance is creating this, what people call this perfect storm, the circumstances, the perfect circumstances. Everything comes together to cause a more devastating storm than ever before, as I will explain in a minute. Now, still, again, I'm confident that there's an opportunity to avoid this, but we need to critically reflect on antimicrobial use and try to reintroduce the basic principles of antimicrobial stewardship in our COVID-19 units. What also still is valid and relevant is this vicious cycle. The basics haven't changed anything, the interaction between antimicrobial exposure and resistance. But what we have seen in the past few months is that we've been using antibiotics much more, and at the same time, probably we've been helping multi-drug resistance spread through our units without even realizing this. And there's a number of mechanisms involved, and I'll deal with these in a minute. Let's maybe just go back a few minutes on what antimicrobial stewardship is. It's this set of coordinated interventions that helps us to improve antimicrobial use as well as improve outcome. I'm sure many of you have been implementing these concepts, this antimicrobial stewardship program in your units in the past years. And what hasn't changed in the past few months is the goals of antimicrobial stewardship. So it's about reducing antimicrobial resistance, of course, still very relevant during COVID-19. It's actually also relevant when we use antiviral drugs in our patients. It's about improving outcomes, minimizing toxicity, and keeping costs low. And when we think of how we've been using antiviral drugs, or supposedly antiviral drugs with antiviral activity, such as hydroxychloroquine, well, we haven't been really improving outcomes and minimizing toxicity. So we should be very critical here as well. Now, I will deal with antibacterial use in the next few slides, but again, just a signal to remember that also for antiviral use, this is highly relevant. Antimicrobial stewardship teams have been introduced in many places. It's teamwork. It's not a one-man or one-woman show. It's people working together, pharmacists, microbiologists, infectious diseases, infection prevention, and of course, I really think this is critical, intensivists should be involved given the high use of antibiotics in our units. Hospital administration should be very supportive, and of course these antimicrobial stewardship teams should have the appropriate authority to deal with the problem. Antimicrobial stewardship has different dimensions. We've already discussed about why we do it, about who's involved. There's also a lot to say about what exactly we should be doing, how can we improve this antibiotic use, and how should we be implementing this. And I won't go into detail, but I will discuss a number of the strategies that can be used and that should be reinforced during the COVID-19 pandemic. Let's go back to when the coronavirus came. Even before the coronavirus, we were already using a lot of antibiotics. These are numbers from the European Union as a whole, in which 30 to 40% of patients hospitalized, so this is not in the ICU, they receive antibiotics. And we know in the ICU it's higher. 50, 60% of our patients receive antibiotics. And the same is true in the community, in outpatient care. A lot of antibiotics being used. And during the COVID-19 pandemic, things actually got a lot worse, not only in the hospitals, but also in the outpatient clinic, where a lot of patients with respiratory symptoms were indeed treated with antibiotics without having a confirmed bacterial infection. So we need to pause for a minute and we need to question what happened. Why did we forget about antimicrobial stewardship? And again, this reflection of what happened is important to solve the problem. Of course, we need to first look at the virus and the disease itself. And I think you will agree with me that in diagnosing a bacterial co-infection, so selecting the patient, identifying the patient who needs antibiotic therapy is quite challenging. This clinical picture of COVID-19 with the hyperinflammation makes it very difficult to discriminate it from bacterial infection, because all these patients have the typical clinical features of bacterial infection, hence the low threshold to start antibiotics. Also, the clinical scenario where patients deteriorate after initial viral infection and then they come in with respiratory insufficiency reminds us of how in other viral infections, bacterial co-infection, superinfection may cause a second hit. And added to this, the problem of having to put on and put off the personal protective equipment every time you want to see a patient, every want to clinically examine a patient, resulted in a fewer clinical examinations. It was more challenging to see a patient and to examine the patient clinically. So all of these things made it very challenging to make a clinical diagnosis as well. And the same holds true for our diagnostic tools, the tools that we typically would be using to diagnose community-acquired pneumonia or hospital-acquired pneumonia have been used in a different way. We were very much concerned about aerosol-generating procedures, such as disconnecting the tube and aspirating or doing a bronchoalveolar lavage, so endotracheal aspirates and BAL samples were much less frequent. Imaging, it's the same story. Especially chest x-rays were quite useless to discriminate between the presence of infiltrates that could be bacterial co-infection compared to the standard presentation of a COVID-19 respiratory insufficiency. There may be some value in CT scan, and I'll come back to that in a minute, but also biomarkers were not really helpful to discriminate between bacterial co-infection and the COVID-19 typical clinical presentation with high C-reactive protein, the lymphocytes as well. So this resulted in a widespread antibiotic use in patients with COVID-19, particularly at the early phase for presumed co-infection. In many institutions, almost all patients received antibiotics at some point during their ICU stay. And these therapies were often combination therapy. They were often sustained for longer than 1 week and often involved carbapenems, fluoroquinolones, all drugs that may impact antimicrobial resistance or have serious side effects. Also, the Surviving Sepsis campaign guidelines on COVID-19 suggested the use of empirical antibiotics in patients with COVID-19 and respiratory failure in intubated patients. And a lot of this was based on extrapolation, data from patients with influenza, with MERS, where 20 to 30% of the patients presenting with viral pneumonia also had bacterial co-infection. So we knew very little at the start, but things have changed, and this is just one graphical abstract I'm showing you from a recent publication from Clinical Microbiology and Infection. This is a living review, systematic review and meta-analysis. This means that it is updated every few months. And this gives us data from December until March. So it's mainly data coming from China, where you can see that a lot of patients received antibiotics, 70+% of the patients got empirical antibiotics, whereas co-infectional presentation, this is all patients, not only patients in the ICU, but co-infection was actually quite low. And of course, as could be expected, a considerable number of patients develops a secondary co-infection at a later stage. Now, these numbers are actually quite similar when we look at data coming from the UK, data coming from the United States. The 3.5% co-infectional presentation, when we look at patients in the ICU only, then indeed numbers will be higher, and 10% has been described. But clearly, not every patient coming in the ICU, coming in the hospital, has a bacterial co-infectional presentation, and not every patient will develop one during ICU stay. It's an important thing to consider. Now, this is, of course, an area where data are evolving, things are evolving quickly, data are coming in almost every week. I'm showing you here data summarized in this letter published in Intensive Care Medicine very recently, experience from Lyon in France, where they looked at patients who were intubated and got an early endotracheal aspirate or BAL, and they found actually that in 27% of patients, bacterial co-infection was documented. Now, note that in the majority of these patients, 12 out of 13, the diagnosis was made based on PCR, and only one actually on conventional culture. So question here is, of course, are we culturing colonization, or is this true infection? And this remains a point of discussion, I think. But we'll surely see more data in the near future. So when it comes to antimicrobial therapy, we are blind when we use our typical paradigm. Then we are not able to select a patient with true co-infection. We have little clues, and effectively this leads to this high use of antibiotics. But it's not only this clinical picture and the viral syndrome as it presents itself. There's also a number of other things, organizational issues, many of them, that we need to consider and that have affected antimicrobial stewardship practices. Maybe your unit looked a little bit like this one. Our hospitals, our units were overwhelmed, and often this led to structural changes in the hospital that really didn't benefit antimicrobial stewardship. So ICUs were expanded, sometimes expanded in areas where people were not used to having ICUs, that were not actually built for this purpose. Patients were difficult to treat. There were needed a lot of procedures and a lot of care. This resulted in a higher workload for the healthcare workers, both doctors and nurses. And this affected everybody's routine. One of these side effects was that we paid less attention to antimicrobial use. We had other priorities. We were discussing when do we have to intubate a patient, how should we set the ventilator setting, should we be proning, what's the role of self-inflicted lung injury, etc., etc. So we had other priorities than antimicrobial use. Other priorities that were relevant was the personal equipment, the protective equipment. And we were very concerned about protecting ourselves, protecting our healthcare workers, which is perfectly understandable. And we were at that moment less concerned with preventing the spread of multi-drug resistant organisms. Now, this is a surgeon, of course, and surgeons typically are in the operating room, but in some hospitals, surgeons, orthopedic surgeons, were deployed to the ICU. Nurses from other departments that have no experience with ICU patients actually were taking care of these patients. So they are unfamiliar, and of course we cannot blame them, but they were unfamiliar with the ICU setting, the typical routine infection prevention practices, and all of this for sure has impacted the spread of antimicrobial resistant pathogens. Now add to this the regular meetings. I mean, we couldn't have physical meetings in our hospital, so the classical antimicrobial stewardship meetings were suspended. There was less interaction with the microbiology and the infectious disease department. And this also may have contributed to our different practices when it comes to antimicrobial stewardship. And add to this the shortages that we've experienced. Probably now this has been solved in many of our hospitals, but initially this came on top of everything that I've already mentioned, and has certainly made things worse. But of course, I do not only want to give you a list of problems and issues, I do hope to give you a number of solutions to reinstate and reinforce antimicrobial stewardship in our units. So the first thing is focusing on empirical use of antibiotics. And I think we need to move away from the idea that every patient that comes in with COVID-19 needs empirical antibiotic therapy. We need to realize that more patients have no bacterial co-infection on admission than patients actually having a co-infection on admission. And of course, we need to understand, and probably we now better understand, the clinical signs and symptoms of COVID-19, and maybe we're already better at recognizing a bacterial co-infection or suspecting bacterial co-infection. We need to look at it from a different, in a different way, and probably, and I already alluded to this, maybe we can use CT scan, not only to exclude alternative diagnosis, but also differentiate between the typical infiltrate of a bacterial pulmonary infection as opposed to the ground glass infiltrates that are typical of COVID-19. Also, maybe ultrasound and other diagnostic strategies could be helpful as well. When it comes to biomarkers, there's of course a lot of attention, a lot of interest in using procalcitonin. It does have different dynamics compared to other classical biomarkers, and it is correlated with disease severity in COVID-19. On average, the concentrations of procalcitonin are quite low at admission, but we know from other infections that it's not so easy to recognize the infection, the patient with infection with procalcitonin on the start, and probably there is some value in recognizing the patient in whom antibiotics that have been started empirically can be discontinued early. But this is certainly one of the areas where we need more research on to better use our antibiotics in the future. So there's also a number of things we can do to improve patient organization. These are all a number of things that Matteo Bassetti and Lenny Derd and myself have been working on, and actually put in a paper that hopefully soon will be published. It's about training and educating our non-ICU healthcare workers, not only on how to ventilate a patient with COVID-19, but also on other basic ICU practices, antimicrobial stewardship, infection prevention. We could use simulation rooms, especially when we are in between different waves. We could, of course, also non-ICU healthcare workers, give them specific tasks that they have particular expertise in, rather than involving them in the standard care of the patients. Reinstating antimicrobial stewardship meetings is, I think, important. And although many of us, of course, have dislike virtual meetings, and I think we've seen enough of them in the past weeks, but this is probably something we can organize in our hospitals. Rather than using universal sampling of the respiratory tract in all our patients, try to identify patients who actually need it. It could be very helpful. And also reinforce these basic infection prevention standards at the bedside, I think is very important. So some recommendations for a rational management of infections in patients with COVID-19 or in the COVID-19 era. Again, I would like to emphasize this challenging this concept of routine antimicrobial coverage for all patients. And this is really a paradigm shift, and it's very important. In the meantime, let's not forget about multi-drug resistance. Let's monitor the epidemiological situation during the COVID-19 pandemic. Consider using surveillance cultures in your unit also in this period. We need cultures. I mean, this is one of the mainstays in antimicrobial stewardship and judicious antimicrobial use. Even if it's difficult, I think we need to be using, we need to be sending samples to the lab still, and of course keep on trying to risk stratify patients for multi-drug resistance. And when you use antimicrobial drugs, well, keep to your basic principles. Stick with the guidelines you have in the hospital. It's not because we are in the COVID-19 patients that 19 era that everybody needs carbapenems, combination drugs up front. Remember, these patients stay in the ICU for quite a long time, and this means they may need these broad-spectrum antibiotics at a later stage. There are a lot of things that we need to work on, that we need to do research on. When we look specifically at antimicrobial stewardship, I think infection biomarker dynamics and trying to elucidate if we can use them to identify the patient who needs antibiotics, who presents with a co-infection or who develops a superinfection is very important. Procalcitonin, again, is one of the biomarkers of interest, but we need more information. The role of imaging and the different imaging techniques, I think, is very important as well. I think CT scan, as we do a lot of CT scan in these patients, we get a lot of information, and CT scan could be a helpful tool. Similarly, in the microbiology lab, let's look at the impact of the rapid diagnostics, not only for bacterial, but also fungal and viral co-infections. And then the last element I would like to cite is the problem of fungal infections. It's something that increasingly is described, but may be related to some of the anti-inflammatory strategies that we have been using. But fungal infections may be a risk in these patients as well, and this needs proper attention. So, in all, I think an important thing is not to ignore multi-drug resistance. It's not because now we have a bigger challenge with coronavirus, with COVID-19, that all of our problems we had before have just gone away. And I'm sure that actually many of these things are still there and probably increasing in the background, and we may not be noticing it. So in conclusion, dear colleagues, I hope to have convinced you that antimicrobial stewardship remains very relevant in the COVID-19 area and should receive the proper attention. A very important thing is to move away, when it comes to judicious antimicrobial use, is to move away from the standard of empirical therapy for all COVID-19 patients. I think the evidence is quite consistent now that not every patient has a bacterial infection on admission, and therefore not every patient needs antibacterial therapy from the start. We need to improve our diagnostic strategy, and I hope to have given you some suggestions on how to do this. Biomarkers are very interesting, but we need more information on how these biomarkers actually behave in these patients. And finally, do not forget that all the organizational changes that we have been doing in our hospitals and in our units also affect antimicrobial stewardship. There is an urgent need to reinstate these principles during the next wave. So I would really recommend you, when you are in between waves of COVID-19, look at the specific issue of antimicrobial stewardship and try to solve it for the future. Thank you very much. And back to you, Marlies.
Thank you, Jan, for a very, very clear talk and a reminder to learn from our first experience in the first wave and to constantly review our practice. The talk was clearly very, very informative and clear. We've had some comments in the chat box saying that people enjoyed the talk, but we've also got two questions. The first question is, does the Surviving Sepsis Committee And the recent guideline suggests the use of empirical antibiotics in patients with COVID-19.
Well, the Surviving Sepsis campaign suggests this in their recommendations, but of course, in all these recommendations and information and guidelines, you need to look at when these were developed. And of course, I can perfectly understand that at the early stage of the pandemic, when we knew very little about how the virus behaves, that at that point we have a lower threshold. And I think now the time has come to reconsider all this information and to look at the guidance. There's many areas, not only infection management, not only anti-inflammatory management, also ventilatory management, where we probably need to do things differently compared to 3 months ago. So I think that's a very important consideration, and many of these guidelines need to be updated. The Surviving Sepsis campaign also suggested against the use of corticosteroids. And of course, now things are different and we know more.
I have one final question. It's not directly related to stewardship, but still very interesting. Is it true that aspirin can be used to treat COVID-19 patients?
I haven't got any information on that. I don't know what the source is, and of course you know as well as I do that a lot of drugs have been suggested not only by doctors and researchers, but many other people make suggestions. And I think for any of these interventions, any interventions should be tested properly before we apply them to our patients. This is really one of the lessons I think I've learned in the past months. Even if a treatment looks very interesting and looks very promising, let's properly investigate this and just not jump onto a treatment only to find a few months later that actually didn't benefit patients, or even worse, that it actually made the situation, made the patients sicker.
Thank you, Jan. As I said, it was very, very informative and very clear. I'd like to invite the audience to continue asking and phrasing questions in the chat box, which I will ask either Jan later or after, or to our next speaker, who is Gennaro De Pascal from the University in Rome. Gennaro is an expert in infectious diseases and intensive care medicine, and will give a talk on managing pneumonia during the COVID pandemic crisis, again with focus on antimicrobial therapy. Gennaro, we are looking forward to your talk too. And again, please, to the audience, continue giving us your questions, and I will ask them to our expert.
Thank you, Merlis, for your kind introduction. Good afternoon, everybody. So in the next 20 minutes or so, I will discuss about the issue and the challenge of the use of antimicrobials in pneumonia during COVID-19 pandemic. So first of all, we know actually very well the vital viral circle. And if we want to categorize and we want to divide the antimicrobial treatment, we can consider treatment, antiviral and immune-based therapy, then the antibiotic treatment, and finally antifungal treatment. So up to now, we have more than 15 million of cases of COVID-19, with more than 500,000 of deaths all over the world. And the main areas now involved by the pandemic are the North America, the South America, India, and the Middle East. We know from the clinical experience that COVID-19 disease may present as a symptomatic or presymptomatic infection, as a mild illness, as a moderate illness, a severe illness, or critical illness in presence of respiratory failure, septic shock, and multi-organ dysfunction. So, regarding antivirals, the expert NIH panel recommend for the use of remdesivir or RNA polymerase inhibitors for all the patients with COVID-19 with SpO2 below 94 on the room air, or those who require supplemental oxygen, A1 recommendation. And the panel recommends again the use of remdesivir for the treatment of COVID-19 in patients who are ongoing mechanical ventilation. The duration of remdesivir therapy may be of at least 5 days and may be prolonged to 10 days in case of no response after the first 5 days. But we know that remdesivir is not associated with increased survival in COVID-19, but only is associated with a reduction of recovery time from 15 days to 11 days. That's why now is ongoing a very large randomized controlled trial, multi-arm controlled trial, comparing remdesivir with HART plus interferon beta 1A in order to verify if this kind of treatment may be associated with a survival benefit. And important to know that in this study, the two arms with the lopinavir, ritonavir, and hydroxychloroquine have been stopped for futility. So the NIH guidelines panel recommends against the use of chloroquine and hydroxychloroquine for the treatment of COVID-19, including high-dose chloroquine. Although there is a preclinical and biological reason to use this kind of drug, we don't have evidence-based data, and the randomized trial that has been published on the New England Journal of Medicine demonstrated that the use of hydroxychloroquine was not associated with a better outcome, including intubation or survival. And it's the same for the combination of hydroxychloroquine plus azithromycin. Also in this case, we have a preclinical reason to use this kind of combination, but the NIH panel recommends against that use. And also we know that macrolides may have an anti-inflammatory benefit, may support immune system against mucoid bacteria, as an antibiofilm and quorum sensing ability, and reports a twice immunomodulatory effect in severe community-acquired pneumonia. And we also know from the H1N1 pandemic that the use of macrolides compared with the fluoroquinolones as part of the antibacterial armamentarium was associated with improved survival. But it's pretty recent, on July 23, this randomized controlled trial where the authors demonstrated that the use of hydroxychloroquine with or without azithromycin in mild to moderate disease was not associated with a better outcome considering a 7-level ordinal scale. It's pretty the same for the highly active antiretroviral therapy, the combination lopinavir, ritonavir, darunavir, ritonavir. Also in this case, the use of anti-AIDS agent is not associated with a better outcome in terms of clinical improvement rate. Instead, we don't have enough data to recommend either for or against the use of COVID-19 convalescent plasma and immunoglobulins, but we have data to support the use of dexamethasone 6 milligrams in all patients who are mechanically ventilated and in patients who require supplemental oxygen but were not on the mechanical ventilator. And the story of the steroids and infectious diseases is an old story. All us as clinicians, we actually know that steroids are recommended and absolutely useful in the treatment of bacterial meningitis, pneumococcal meningitis in adults, and Haemophilus influenza meningitis in children, for tuberculosis in meningitis and pericarditis, for pneumocystis cerovaceae pneumonia, and also for severe community-acquired pneumonia. These are the results of a very nice, a very interesting paper from the group of Tony Torres, where the authors observed that using methylprednisolone in patients with severe community-acquired pneumonia and a high level of inflammation, as demonstrated by the high level of C-reactive protein, was associated with an improved, a better outcome, including clinical aspect and radiological findings. And also in the early phase of the fibroproliferative process of the RDS, we know from the literature that there is a trend for a better outcome using steroids. Why desamethasone? Because we have the preliminary results of a very large randomized trial in the UK, and its name is Recovery, where desamethasone reduced death by 1/3 in ventilated patients and by 1/5 in other patients receiving oxygen only. Instead, there was no benefit among patients who do not receive oxygen or ventilatory support. And finally, for the antagonist of interleukin-6, we don't have enough data for either for or against the use of this kind of drug. We have principally observational data, such as our data from the Gemelli against COVID-19, both for sarilumab and tocilizumab. Let's jump to antibiotics. As Jan already said, the Surviving Sepsis campaign suggests in mechanically ventilated patients with COVID-19 and respiratory failure the use of empirical antibiotics over no antibiotics. And this is a recommendation, is a weak recommendation, because the evidence is of low quality. There are no, in fact, controlled clinical trials that evaluate the use of empirical antimicrobial in COVID-19. Although more than 50% of the patients with non-severe disease and almost 100% of patients admitted to the ICU receive antibiotics. But no, we know the experience of H1N1, where the rate of co-infection was pretty high, including the bacterial co-infection with Streptococcus pneumonia and Staphylococcus aureus. Also, in the Annals of Internal Medicine, there is a strong suggestion for the use of empirical antibiotics in severe patients when a bacterial co-infection at diagnosis is suspected. And regarding antibiotics, there is no specific recommendation a part of the guidelines. Instead, the authors highlight the importance of the microbiological collection, maybe the sputum, maybe endotracheal aspirate, maybe bronchial alveolar lavage, in order to de-escalate promptly as soon as possible. And regarding the therapy, if we want to cover from the beginning bacterial co-infection, we can rely on the last guidelines of the ITS using a beta-lactam combined with a bronchiolide or a fluoroquinolone. Instead, if we consider the hospital-acquired infection, first of all, we have to ask whether the patient is in a low MDR category or in a high MDR category. Is there present septic shock or no? Because the therapy may be very different from a simple ertapenem or ceftriaxone to a dual-gram pseudomonal coverage plus MRSA therapy. As Jan said, the microbiological diagnosis of respiratory co-infection or superinfection is a challenge because, we have to use all the PPE in order to reduce the aerosolization of the respiratory secretion in order to reduce the possible transmission of the virus. However, we know from the literature that there is no evidence that endotracheal aspirate may be better or worse than bronchoalveolar lavage, although the latter is associated to a higher percentage of the escalation. Instead, for sure, bronchoscopic procedures should be reduced in the necessary way because these are associated with a higher spread, higher aerosolization of respiratory sample. And here you can see the example of a mini bulk procedure. This is not a patient COVID-19. The operators do not have glasses. And you can see here that the circuit is actually closed and the procedure is pretty safe. If we have a look to the literature now, the literature is mainly composed by a case series or cohort study of bacterial co-infection or superinfection. This is a very interesting experience with actually 32 patients where the authors did not initiate antibiotic therapy in an empirical way, but performed a film array pneumonia panel, so a PCR test on the endotracheal aspirate and in some cases on sputum. And by this way, the authors were able to diagnose different bugs. Also in this case, it's difficult to differentiate from colonization to real infection, although we had a unit forming colonies for the Film-Array pneumonia, and so they were able to target the subsequent antibiotic therapy according to the microbiological results. It's also interesting the Italian experience of Giacobbe and Bassetti, where the authors analyzed 80 patients with COVID-19 and observed that the frequency and the prevalence of bloodstream infection was higher during the course of the ICU stay, and also observed that the occurrence of bloodstream infection was associated with impaired survival. And another interesting report is this cohort study on 65 patients with nosocomial superinfection. You can see here that the majority of the patients receive antibiotic, cephalosporin, beta-lactam, beta-lactamase inhibitors, fluoroquinolones, and the main infection sites were pneumonia, bacteremia, and UTI. This is another very nice experience recently published on the clinical infectious disease. Almost 300 patients with a 31 respiratory co-infection, Bordetella, Staph aureus, Streptococcus pneumoniae, and 11 subsequent respiratory infections. Also in this case, the occurrence of a co-infection, respiratory co-infection or a respiratory superinfection was associated with a worse outcome. And again, from the clinical infectious disease, in the cohort of 321 patients, the percentage of microbiologically confirmed pneumonia was very low, less than 5%, but the percentage of antibiotic use was 70%. And yes, this kind of contrast is really, really striking. And when we analyze the patients during the ICU stay, we can also observe multi-drug resistant germs affecting the patient. For example, this is a case series published on clinical infectious disease, where the authors started with the piperacillin tazobactam, and then they were obliged to escalate to imipenem, ceftazidime avibactam, ceftolaids, and tazobactam because of the isolation of Burkholderia cepacia, Pseudomonas aeruginosa, and Stenotrophomonas maltophilia. Up to now, we have a couple of systematic review, including the first 18 studies, the second 28 studies, which tell us that the rate of initial co-infection is pretty low, less than 5% and roughly 8% in ICU. And the rate of secondary infection, so after the presentation, so nosocomial infection, is higher, about 50%. However, the rate of antibiotic prescription is always high, 70% in this meta-analysis. And these numbers are confirmed by this other cohort study where 7% of the patients with SARS-CoV-2 infection had another infection, mainly bacteria, and the authors compared this kind of infection with H1N1 influenza pneumonia. And they observed that actually in influenza, the rate of bacterial co-infection was significantly higher. And it's also true that in the ICU setting, the rate of bacterial co-infection and superinfection is higher compared with mixed hospital patients. This is our experience in Gemelli against COVID. For Staphylococcus aureus VAP, we observed a pretty high incidence of Staph aureus VAP with a very high prevalence of bacteremic patients and MRSA. However, the only predictor of 30-day mortality was the initial inadequate antimicrobial therapy and not the status, the presence or COVID-19 disease. If we speak about Staph aureus as one of the main bacterial agents that may complicate in the early phase also the disease, the COVID-19 patients, we have to bear in mind that teicoplanin, a glycopeptide, is also active against the MERS virus, so the MERS coronavirus and the SARS coronavirus too. So maybe another reason to use this kind of glycopeptide. It's very interesting, this experience published on intensive care medicine, where 13 patients with bacterial co-infection were compared with 35 34 patients without bacterial co-infection. And you can see here that demographics, comorbidities, clinical course before invasive mechanical ventilation, organ failures at admissions, and laboratory measurements are actually the same. So we don't have at now elements to early identified patients with bacterial co-infection at illness presentation. Another possibility is the co-infection of SARS coronavirus 2 with influenza virus. Also in this case, the clinical picture is the same as you can see here with a ground glass image and the crazy paving. In critical ill patients, so also in COVID-19, when we decide to start with antimicrobial therapy, we are building up a puzzle. So we need to know the pharmacological issues and aspects of the antibiotic we use, the infection site, the patient's pathophysiology, and the MIC of the pathogens. And also we know, especially for multi-drug resistance bacteria, that the initial inappropriate antibiotic therapy is associated with increased mortality. So it's really important to know which are the patients at risk for multi-drug resistant germs, including therapy-related risk factors, patient-related risk factor, and antibiotic selection pressure. Then we have to follow the rules of PK/PD, considering concentration-dependent and time-dependent drugs, hydrophilic antibiotic and lipophilic antibiotics, how their pKa may change according to pathophysiological status of the patients. Well, it's unclear whether the reported low co-infection rate is the result of a large scales of empirical antimicrobial administration or derived from the limitation of the clinical examination during the pandemic. But we absolutely know that if the rate of broad-spectrum antibiotic prescription is so high, this may represent another issue for the treatment of COVID-19. So the multi-drug resistance. And you all know the multi-drug resistance cycle, where the presence of resistant microorganism is a trigger for a broad-spectrum empirical treatment, which is associated with an increase of resistant microorganism, which is the trigger for an increase in adequate empirical treatments. We don't have reason to treat differently COVID-19 patients compared with other critical ill patients regarding the escalation. So the de-escalation rules are the same, and the duration of superinfection, nosocomial superinfection, also may be the same, between 7 and 10 days. In this case, we can also may be supported by the use of procalcitonin. We know that procalcitonin is not so useful for the diagnosis of pneumonia or ventilator-associated pneumonia, but we have very solid data which demonstrate that with procalcitonin we can significantly reduce the drug exposure. So the de-escalation or escalation, we have to look at the source control, the clinical improvement, the appropriateness of therapy, and the biomarkers decline. Finally, antifungal therapy is a part of antimicrobial armamentarium. We know that adequate antifungal therapy is one of the key factors for a good outcome during the treatment of a fungal infection, and we have reports of fungal infection, including candidemia and isolation of candida from the BAL. But we have to be reminded that the isolation of candida from the BAL is only colonization of the respiratory tract, it's not any real infection, but may represent a problem for other non-fermentative gram-negative routes, such as Pseudomonas, which can cause subsequent VAP. Regarding antifungal approach, we can use a prophylactic, but it's not supported, empirical approach, preemptive approach, or targeted approach. We can be supported by the Candida colonization index, by the Candida score, or by the 1,3-beta-glucan assay, which is a marker of Candida infection. And this kind of biomarker has been associated with a significant reduce of antifungal days in patients with suspected invasive candidiasis. These are our data recently submitted. And we actually have the possibility to encounter an aspergillosis in patients with COVID-19. This is a known story for H1N1 pneumonia. So aspergillus is pretty frequent superinfection in H1N1, but we have also report of aspergillosis in COVID-19. Regarding aspergillosis, it's very important to differentiate Aspergillus colonization from proven IA, from putative IA, and for the diagnosis, we have to include three elements: the clinical risk factors, the radiological findings, and the microbiological findings. And among the microbiological findings, it's very important the use of galactomannan, especially in the bronchoalveolar lavage. So we need, in this case, an invasive procedures. Last slide is a possible co-infection with pneumocystis jirovecii. I didn't find nothing in the literature in PubMed, but from a clinical point of view, we have to recognize and acknowledge that the clinical picture of pneumocystosis may be similar to COVID-19. In this case, the use of beta-glucan is very useful because it's a non-invasive marker with a very high accuracy for PCP diagnosis. In conclusion, for the antiviral strategies, we have now remdesivir, but we are waiting for new antiviral strategies. We have to understand when and how to blunt immune response. And at this stage, we can use dexamethasone for moderate and severe disease. Antibiotic, yes, in severe cases, but after cultures and with prompt de-escalation. The biomarkers should be used in a rational way, so procalcitonin, C-reactin protein, beta-glucan, prodronomedulin, or galactomannan. And finally, we should be updated with upcoming evidence, which is the best way that we have to treat our patients. Thank you for the attention.
Thank you, Gennaro. Gennaro and Jan, both of you have suddenly attracted many, many questions. The chat box is full, and I think the audience knows that you're both experts in this area, experts in infectious diseases and COVID-19. So I will summarize the questions, and I'd like to start with a question for Gennaro first. There are quite a few questions related to opportunistic infections. When should we think of opportunistic infections?
It's a very interesting question because opportunistic infection may happen in COVID-19. I think that if we want to categorize the two types of infection, co-infection that patients may have, co-infection and superinfection, is actually more frequent to encounter and treat an opportunistic infection as a secondary infection because the patient's immunocompromised, because the patient receives corticosteroid, probably antagonism of interleukin-1 or interleukin-6. In this case, the opportunistic infection may be viral reactivation for herpes, for example, or cytomegalovirus or Epstein-Barr, maybe fungal infection and mold infection, maybe a pneumocystosis, for example. And in this case, we have to use all the non-invasive diagnostic tools that we have, so the biomarkers, but probably to be accurate in the diagnosis, we have to perform a bronchoalveolar lavage. A mini bronchoalveolar lavage with a closed circuit may be okay, and a PCR test, a molecular test on the bronchoalveolar lavage may support us for this kind of diagnosis.
Thank you. There's a related question or a question following on from this. If you do some tests, including a bronchoalveolar lavage, and you find Candida, is this an indication for antifungal treatment? And if so, which one would you recommend?
Okay, so the isolation of Candida, so of yeast from the bronchoalveolar lavage, a part of leukemic patients with deep-sited candidiasis, with hepatosplenic localization of the infection, represents a colonization, is a marker of dysbiosis, and is associated with increased risk of non-fermentative gram-negative VAP. But there is no need to treat Candida albicans colonization in the lung, so there is no antifungal drug to be used.
Thank you. I have one more question for you, and it again relates to diagnostics. And the question is, how frequently should we check PCT, procalcitonin, in patients with COVID-19?
There is not a recommendation in the NHA panel, also in the Surviving Sepsis campaign, but we can suggest to check procalcitonin at the beginning of the disease, because what is important is not the single level by the trend, and then repeat the procalcitonin test after 48, 72 hours in order to have an idea of the trend. Because in the first 2-3 days after the diagnosis and after the empirical treatment initiation, we can see if the patient is going to have a clinical cure or not. And in this case, a biomarker like procalcitonin may be used to support our antibiotic strategy, or to support the change to another antimicrobial, or to support a de-escalation.
Thank you, very clear. Jan, I have a question for you. Actually, there are several questions, but I will summarize them. I think the message is clear, or your message was clear, to avoid empirical antibiotics. But here's the question. What is your threshold for initiating antibiotics? And if so, which antibiotics would you recommend for empirical infection of the lungs in patients with COVID?
Two difficult questions, Marlies. Now, first, let me be clear. I think we need to avoid antimicrobials when patients don't need them. There may be a very small number of patients who do need them, so we need to be selective and only use them in patients who actually have the highest probability of bacterial infections. So that's the challenge. Now, it's quite challenging, of course, to say what the best approach is. When it comes to which antibiotic to give, then I think you need to follow your local recommendations, and what works in Ghent may not work in Rome or may not work in London, and vice versa. So this is about sticking to the guidelines that you are using. And these patients, most of these patients come from the community and should be treated as community-acquired pneumonia, bacterial community-acquired pneumonia, and use your standard strategies. As I mentioned, there's a lot of new information coming in. We've had no patients almost in the past 6 weeks. There's a number of patients. The numbers are increasing again, and I think we need to redefine our approach to bacterial infections and empirical antibiotic treatment in the next weeks. I think we should be integrating the use of rapid diagnostics, if you have them available, could be very helpful. If you do rapid diagnostics on an endotracheal aspirate, on a BAL, and you find nothing, well, then clearly there is nothing, and these patients probably would not need antibiotics. CT scan, again, we've seen a lot of CT scans now. We learned a lot, and we recognize this typical ground glass aspect of the lungs, which is completely different from bacterial infection. And I think combining, for instance, these two could be a sensible approach to minimize antimicrobial therapy, empirical therapy. So still, a number of patients probably need it, but it's not the majority, as we've been doing in the past. It's rather a minority. And I don't know, Gennaro, how in Rome you will be approaching this problem, but probably different from what you did in the first wave.
Gennaro, do you want to comment too? Do you have any advice when to initiate antibiotics in COVID-19?
This This is a really issue and challenging. I perfectly do agree with Jan that probably compared with the early phase of the pandemic, now is the time to use in a more rational way our antibiotics and stick on the clinical findings, on the radiological findings, on the use of biomarker, and on the new technologies for microbiological identification. For example, the film array pneumonia panel is really important, its use in these cases, in order to start with antibiotics. And so probably the starting antibiotics may be on not so broad spectrum, with a narrow spectrum, but also always guided by the microbiological findings.
Thank you. I have a difficult question here, and Jan, I'll give it to you. I give it to you because you earlier on said that in the next wave, we probably will use diagnostics and imaging more frequently. And you mentioned CT and ultrasound. And the question is, will CT and ultrasound of the lungs help us deciding which antimicrobial to use?
Well, they may help us to identify patients who need antibiotics. I think we should be very cautious in using these diagnostic techniques to guide us, to help us guide what kind of antibiotics we would be using. I'm not aware of any imaging technique that is actually helpful to distinguish between different kinds of bacterial infections. And I would be very reluctant to use it. Again, I started also with this comment, and we need to realize that we've been jumping on a lot of therapies, on a lot of strategies that in the end proved to be wrong, proved to be not helping the patient, and in some occasions proved to be damaging the patients. And I think we need to be very, very careful in the next wave and more critical and do better research before we do anything that could potentially harm our patients. This is something that is relevant for antibiotics, but for each and every aspect, when it comes to early intubation or not, when it comes to the use of steroids, when it comes to the use of hydroxychloroquine. I mean, we don't know the disease, and if you don't know something, then you have to study it before you give potentially toxic drugs or interventions to patients.
Thank you very much. And on this note, I'd like to finish this session. It's been very, very informative. I'd obviously need to mention that we talk about the next wave because we've been through one wave, but there are a lot of people in the world who are currently going through their first wave or already in their second wave, and they're in the midst of it. So every day is a school day for all of us, and we're learning from each other. Webinars like this are very helpful and are reminding us to keep our eyes open and learn from our colleagues. So I'd like to thank both of you, Jan and Gennaro, for sharing your experience and informing us. I'd like to thank the audience for listening. I'd like to thank all of those who are currently in the midst of a pandemic and are trying to fight COVID-19. And then finally, we have to thank the ESICM for arranging another very educational webinar and selecting expert speakers. Thank you, everybody, and have a good evening.
Thanks to you.
Thank you. Bye-bye.